welcome back. Hopefully everybody got a little bit of lunch. My name's Justin Jordan, and I am one of the co-chairs today, and for those of you who came for the afternoon session. And we're going to talk next about the survey that Sarah discussed earlier. So coming into the patient day today, we surveyed both patients and caregivers as well as physicians and tried to begin to anchor a conversation around mutual priorities so that, as I mentioned before, we can make sure that the scientific work that's happening in the background is important and meaningful for patients. So I'm going to talk about those survey responses with you here. Okay. So the way this was done was surveys were sent to an international collection of patients and caregivers, as well as clinicians and researchers who have been involved with the Children's Tumor Foundation before now. We got feedback from each group and looked at the data for similarities and disparities in priorities. And then we have chosen topics for oral presentations, as well as roundtable discussions that we'll have here in just a little bit. So the first thing that we'll talk about is what is your NF diagnosis? This is just a little bit of demographics. So 72% of the respondents had NF1 compared to 24% with NF2 related schwannomatosis, and then 3% with other forms of schwannomatosis. You can see that we had a wide representation around the globe in terms of location for people who responded to the survey. When we asked about which symptoms cause the biggest concerns for overall health, we asked patients, how is your health most impacted? We asked physicians, what do you think are the complaints you hear most in your clinic? And you can see a couple of the differences there. First of all, pain is a common complaint or symptom that patients experience, and physicians echoed that. You can see with the blue arrows that was sort of felt mutually across the respondents. Compare that, though, to the orange arrows, which is weakness, numbness, and tingling. Patients reported this. 33.9% of patients said that this is one of their biggest concerns, whereas we only heard it from about 16% of the clinicians and researchers. So with this, we began to identify where some of the differences come in physician and researcher focus compared to patient focus. We looked at quality of life here, and specifically which symptoms or issues are the greatest challenge for your quality of life, again with the same sort of comparative question for physicians. And you can see that there were some differences here. So patients reported social interactions and long-term life planning were very high at the top of their mind as it came to quality of life, whereas those came relatively lower among physicians, and instead attention hyperactivity disorders and pain and itching were ranked more highly with physicians. So this type of disparity turns out to be really helpful as we have community-level discussions to make sure that we're focusing on the right outcomes. When we looked at the obstacles that patients report encountering to find accurate and relevant information about their condition, physicians see themselves as the primary point of contact in sharing information with patients and families, but patients say they don't actually get enough time with their physicians, which I'm seeing a lot of heads in the audience that suggest that they may that may be experience that you have as well. And so I think it's important that that we talk about that and try to figure out what are all of the opportunities for accurate and reliable information. Looking at types of research that are of interest to patients. Both groups expressed excitement about the idea of gene therapy. So thank you, Dr. Blanco, for the discussion earlier on gene therapy. and predictive biomarkers, which is great. Patients also reported excitement on treatments to prevent symptoms and for treating symptoms that exist already. When we looked at outcomes for clinical trials, we asked patients, which outcomes would you like to see measured in determining the success of a clinical trial, and which outcomes would you like to see? I think that's the same question, okay. And you can see that actually there's a fair amount of similarities between patients and doctors and scientists. So decrease in tumor size was very relevant for both populations. Enhancing the quality of life was very relevant for both populations. A little bit of difference in pain scores. That didn't come quite as high for patients as for doctors. But having trouble seeing the screen, sorry. Decreased risk of cancer metastasis, interestingly, was higher for patients than for physicians. And so I think that actually this creates a really nice opportunity for sort of some of the discussion that we'll have in a little bit today as we begin to think about these outcomes. So both groups reported that they'd like a chance to talk and work together in focus groups. And so we have a lot of time this afternoon dedicated to that. And some of the topics that we're going to ask for input from you in the audience will include topics about pain, patient registries, as we just heard about, barriers to participating in international research, equity and access to care, as we discussed this morning, communicating about NF to the non-NF community in terms of advocacy, and resources for school, which we know is very critical for patients and their caregivers for young individuals with NF. Later this afternoon, we'll engage in targeted brainstorming around these topics so that we can hear your voices, and that'll be helpful as the Children's Tumor Foundation comes back together, driving so much of the innovation and the research that we're doing in these disorders, and make sure that what we're doing is reflective of what's important to you. We hope that today has been informative so far, and that this afternoon you'll find value in a sort of community level discussion, and also being able to share your lived experience and values. So thank you very much. I'm next going to invite Sarah Lees back up so she can guide us in our next activity.
All right, thank you so much. So, I mean, overwhelmingly, we saw on our survey feedback that finding community, finding people with a shared experience was a gap for many of you. And so if you'll notice, some of the chairs have been moved around in here. So what we want to do is just have people break into random groups, and we're going to give you the next little bit of time to get to know each other, share your stories, talk about concerns that you have or barriers. As Justin went over, there's a couple of topics we've identified to do sort of roundtable brainstorming in a little bit, but those don't have to be the topics we choose. We could go with other topics if there's things that you identify as you talk in your groups that are more concerning to you that we would want to find solutions for. And then in the very end of the afternoon, we'll go through a brainstorming activity. We don't want it to be all words and no action. All this morning we talked about patients need to be engaged in research, patients need to be engaged in identifying the resources, patients need to be engaged in participation. So we want to engage you this afternoon and ask you for your feedback on what sorts of research should we be funding, what sorts of educational materials do we need to be creating, what are the things that we can do to help you with the things that you know are the hardest for you to identify. So what I would like to do is designate this front circle up here if we have anyone who exclusively speaks French and does not speak English. And then we'll have the other groups can be mixed. If there's anyone else that has a single language, if you can come and find me, we'll see if we can find some people that will work with you, because unfortunately the headsets only work when we're speaking through the microphone. All right? Okay, so exclusively French speaking. Anyone else can go anywhere else. And if you are not one of those two, come find me and we'll make sure we find a space for you. And then just have some conversations, get to know each other, build community. All right, so hopefully you all have gotten to know each other quite a bit and maybe discuss some of the problem and pain points that you're hoping we can address. What we're going to do now is remember what circle you were in, okay? Go back to the seats in the middle. We're going to invite our co-chairs back up, so we'll have Dr. Blanco, we'll have Dr. Jordan, and we'll have Dr. Legius up here, and you can ask them any questions that you would like. This is your chance to get your burning NF questions answered. And then we'll come back to these breakout groups to brainstorm after the break.
Hello, my name is Catherine and I'm from Ireland. I'm a patient ambassador and I'm also the European patient representative for NF1 along with Sophie who's here as well. One of the burning questions or issues that I have is the transition from pediatric to patient care. And I can tell by the nod of your head you already know this is an issue, but I know it's across the board. You know, it's fantastic that we have all these trials going on, and you know, it's so important to get these certain ones early on in kids, but we know this is a progressive disease. So why aren't we putting this much resources into adults who are maybe 60%, 70% into that progression? You know, there mightn't be a turning point or going back, but where's the, I don't even want to use the word palliative care because it's not palliative care, but where is the care and the passion for the adults? Like that, it's fundamental. And it's also a mental game, this waiting game that we constantly have when it comes to our appointments, and getting the seriousness of what it is to us across to the doctors.
We can explain the history here in Europe and probably in US. As you say, it's a general problem and it's not already solved. When someone, for example, in Spain asks me about that, I say, okay, I'm fine, because in Spain there are two national reference centers. Both are in Barcelona. One is for pediatric and one is for adults. Patients that came to the reference center in Barcelona for pediatrics, I will say 90% came to our center later. However, this is not the same in other areas of Spain. And you are right. We need to push to stratify and to be sure that patients go along from pediatric to the adulthood. Because if not, many patients are lost in the way. One of the funny things is when I talk with my colleague in the pediatric area, he has a lot of patients with TA, autism, or problems with the knowledge, and we don't have that in our series for adults. And the question is, where are these patients? And for that, I think that we need to specify the way that patients should go to the adult hospitals or adult healthcare, at least in Europe. We are trying to make it, but you have to push us to clearly clarify.
This is a worldwide problem. So in the US, I will say that there's a few things we're thinking about in terms of expanding access to care for adult patients with NF1. The first is actually the Children's Tumor Foundation has a granting mechanism in place and has awarded a grant to 2 centers around the country in underserved locations to establish a new adult clinic for NF1. They've provided mentors from other well-established NF1 adult clinics to help get those clinics off the ground. So I think that there's a deep commitment there to build and expand adult care. There's also, I work at Massachusetts General Hospital, and one of my colleagues, Vanessa Merker, who was on the stage earlier, actually has a couple national awards to help inform primary doctors about best practices for care for adults with NF1, recognizing that many people who are adults with NF1 may not find themselves in a center of excellence. How can we empower those patients to advocate for themselves with their primary doctor? How can we educate the primary doctors all remotely and make sure that they're at least getting the fundamental level of screening and education? And then the last thing is, I think probably inherent in your question is the idea of sort of transitioning from a pediatric clinic to an adult clinic when you have access to an adult clinic. And there's a lot of work going on in that context as well, trying to identify best practices for cross-communication between pediatric and adult clinics so that the handoff is as smooth as possible, even recognizing it's changing providers, it's changing teams. That's uncomfortable, but at least you can prepare the next team for the background and everything that the individual needs for their ongoing care.
As last person in the row here, I want to add that we are also wrestling with this question. That's why tomorrow at the comprehensive care session, we have a specific talk on the transition from pediatric care to adult care. And it is not something where you can give a solution that works for all, because healthcare is organized differently in different countries, even in the same country and different hospitals. Care for NF is organized in a different way. But what you can ask your local NF center is that they come up with a program of transitioning from pediatric care for children to care for adults. And then together with you as a patient representative, they should work out a program that works in your situation.
I think there's another aspect on this problem, that most young children and older children come with their parents, and their parents take care of the appointments. And then when they are young and young adults, they want to be a young adult and not a patient with NF. And that's also a problem, I think.
They disappear from the statistics.
And also that's about you talking about the patients with maybe less mental skills, that they also disappear for that reason.
Yes, totally agree with you. That's a real problem. And also I will say that, for example, I'm a adult patients clinician, and the way that we approach diseases, not only neurofibromatosis, is completely different from the pediatric area. As you say, in the pediatric area, parents bring the child, and also you have many appointments trying to look for everything. When a patient came to our clinic, the first thing that we say is, okay, you will have to let you know, to us know what we have to do, because we won't be in a regular basis or whatever. And then patients with some problems with the communications get lost. They don't come to us. That's a real problem.
Hi. Lately I'm hearing from parents that doctors are a little bit anxious to do surgery, to perform surgery, because the tumor is most likely become cancerous. And I want to know if that is true. And if you decide to do the surgery, why, if there is a big chance it become cancerous?
This is again a problem of communication. From my point of view, it's completely normal that a parent that knows that there is a risk of malignancy wants to have all tumor removed as soon as possible. We as a doctor, we know that sometimes doing things is worse than wait. But we have to communicate to the parents in a, I would say, normal way. Because if we operate all tumors, probably the patient will have more consequences. But if a doctor say, okay, you don't need to operate, and that's all, the parent will start thinking, oh, my kid will get sick. I'm sorry if I don't understand your question, but I used to say that many time ago. If we remove a plexiform neurofibroma, if you don't remove all neurofibroma, probably the rest of the tumor will become malignant. We know that right now, this is not completely sure. Every case is different. And for that, I'm saying that we have to have a very good communication, doctors and patients, to understand the decisions and the problems. That's my point.
We recently have seen that if you follow a tumor over time, that some tumors gradually change from a benign neurofibroma to an intermediate stage, which we call atypical neurofibroma, and from the atypical stage, it might proceed further to a malignant stage. So now we have 3 different types of tumors that we can recognize on MRI scans and PET scans. And this is especially the case in, let's say, like young adults. We know that if these tumors are changing from benign over atypical to malignant, that very frequently these tumors become symptomatic, meaning that they cause pain and discomfort and everything. So in the old days, we used to treat patients when they had symptoms. But these tumors that were symptomatic were already somewhere progressing from a benign tumor towards a malignancy. And we now understand that the tumors that were treated before, some of them were already in a process of becoming malignant. And it's not by doing the surgery that they became malignant afterwards. But there is this correlation between having a tumor that is causing symptoms and a tumor that is also becoming malignant. So in the old days, people thought, if you do surgery, then it becomes malignant. But that's not the correct reasoning. We now know that these tumors have the potential of becoming malignant. They have the same potential of causing symptoms. And now we know better how we have to monitor these tumors and choose a good time point to remove them, but only those that are in the process of transitioning from an atypical neurofibroma maybe to a malignant tumor.
And that's something you can see on an MRI? It has a different structure?
Not only on MRI, but also on PET scan. And if there is doubt about the fact that is it now transforming to atypical or malignancy, you can do a biopsy if you're unsure. So nowadays we are sitting together with a person who has knowledge about neurofibromatosis, a person who knows how to do surgery, an oncologist, and so on. So we sit together with a group of people and decide, are we going to follow the patient further? When are we going to do the next scan? When are we going to do a PET scan? Are we going to do a biopsy or not? So all these things are now put on the table, and then a multidisciplinary team tries to come up with the best suggestion for that particular patient. And that is not always simple, and there are no, let's say, good guidelines to do this. And that's why we always try to improve surgery, because if we could predict which of these atypical tumors are going to proceed to a malignancy, we would only take out those. But we cannot do that at this moment. So we probably are taking out too many tumors to prevent them from becoming malignant, where not all of them would have proceeded towards malignancy.
Thank you.
Hi, Kimberly McCoy. I live in Sweden, and my daughter has NF1 and a plexiform neurofibroma. To what you just said right there, Dr. Legius, about predictability, what are the chances, or what are the opportunities there to look at predictability of disease progression? Will there ever be a time when I sit in the neurologist's office and they say, your daughter's going to be okay, or is that completely out of the realm of science right now? Yeah, there is some evidence at the moment that especially nodular-shaped neurofibromas have a higher potential of becoming atypical and then further move towards malignancy. Those are the tumors that we can identify, but they are usually not on the outside of the body. They are quite often on larger nerves, deeply seated, and so in fact you need something like a whole body MRI to find them. And that's why in the GENTURIS, which is the Genetic Tumor Risk Syndrome European Reference Network, we came up with guidelines to suggest that maybe somewhere at the age of transition from pediatric care to adult care, you should do maybe, if that's possible in your healthcare system, once a whole body MRI. At this moment, we believe that if this whole body MRI is completely normal and doesn't show any of those nodular neurofibromas, of course there are always small neurofibromas of 1 centimeter or so, that if there is no nodular neurofibroma that is suggestive of that type that might progress towards atypical or malignant tumors, then the chances are relatively low that this person will ever develop a malignant tumor of the nervous system. But we also know that not all malignant nerve tumors go through this process of atypical neurofibromas. So we have to be careful there. We cannot rule out everything, but we can reduce the risk by saying, okay, we didn't see anything, and then it also is not relevant to repeat that in 2 years or in 5 years, because we know there is nothing now, and we believe that the origin of these tumors goes back to the time period before birth. So they should be there in adolescence, and they should be detectable. And those that follow this route can be detected and maybe prevented by taking them out when they start to degenerate into a malignant tumor. Those that don't follow this route, we cannot do anything about them. And because there is some evidence that also very small tumors hidden somewhere might become malignant, but this chance is much, much lower.
I'll just put a couple more pieces of hope on the horizon for you. In addition to what Dr. Lee just said, there are a lot of researchers that are working at the intersection of radiology and neurofibromatosis and looking at not only nodular lesions, but what are the other aspects of a tumor that may go on to become atypical or malignant. If you've ever had an MRI before, you're in the machine for ages. There's a lot of information that's obtained there, and so looking at all the different types of information, using machine learning and artificial intelligence to try to figure out a risk modeling for which tumor may be problematic. And then the other piece of hope on the horizon is the transition from benign to atypical to malignant has some pretty well-defined genetic changes in the tumor along the way. And so there are a lot of people looking for the equivalent of a liquid biomarker so that maybe you could have a once-a-year blood draw and figure out if any of those gene changes have happened that might increase your risk of having a malignancy down the line.
Hey, are there any studies about the effect of a specific diet on NF1 or other NF types? Like, you know, like liver, like, in some other diseases, like keto diet, I think, and then positive results. Is there something similar going on?
At the moment, there are no large studies showing that specific diets have a good or a bad influence on the course of neurofibromatosis. There are some small studies where a couple of patients are reported that follow a specific diet and then they have more or less complications than expected, but these are very small studies and we cannot rely on them. The only thing we know at the moment is that many patients with neurofibromatosis seem to have a low level of vitamin D. We don't know what the benefits will be of increasing this level of vitamin D, but it certainly will have some benefits. We don't know if it will influence the course of the disease or not, because there are, like, large studies are lacking. But I think that there might be a number of studies funded by CTF looking at certain specific diets, and also in the comprehensive care session tomorrow, we will also focus on vitamin D and other supplements to see if they have any effect on the course of the disease. But this is still under investigation.
No, only to point out that we have to be very careful with the results from a few number of patients, because that is, I will say that from our clinical points are not reliable. We cannot trust with a small amount. As far as we know, a diet that increases variety of foods, vegetable, fruits, and if you put also other types of healthy life, like exercise, that can make your life better, not only for neurofibromatosis, if not also for other things. We have to be very careful.
Thank you. We do have a question regarding the link between NF and thyroid, if there is any connection with problem with thyroid. So I'm not sure about the pronunciation, but it's la thyroid. And if thyroid.
We do not have evidence that there is an increased risk for thyroid disease, but there might be a small increased risk for parathyroid disease. So within the thyroid gland, there are some other cells that are responsible for the secretion of a parathyroid hormone, which has an effect on the calcium level in the blood. And I personally have seen a couple of patients with multiple parathyroid adenomas. So these are benign little tumors of the parathyroid glands, which are located just next to the thyroid gland. And there is probably an association, but it is not very well described in the literature, but that might be one of the things.
Hi, so I represent an organisation in the UK, and a lot of the questions we get asked is around radiation and X-rays. So we tell people to avoid radiation, and then they contact me and say their child's got to have X-rays, and they go into a bit of a panic, and I'm not really sure how to advise it. I know it's avoid. It's not don't have them, it's avoid. But what should I be telling them?
This is something that we think about pretty often. Certainly in the context of malignant risk, we know that damage to DNA increases the risk of cancer. We know that NF1 carries the risk of cancers. And so in some of the published care recommendations, it does specify that MRIs are preferred over things like CAT scans when possible. It's true that there are some parts of the body and some tissues that are just not well visualized on CAT scans. And so certainly I think it takes a careful discussion with your provider about the specific question that's being asked with the imaging, with a strong preference for MRI scans as a first line. But sometimes you have to see what you have to see. And so as long as it's a careful discussion weighing the risk and benefits, I think that that's the most important.
For example, if we are thinking in a gastrointestinal tumor, maybe CAT scan is better than MRI. We have to have this balance. We know that exposure of X-rays is not good for NF1 patients. However, sometimes we need to do it. We have to have the balance.
Difficulty I have is that a lot of our members are not seen by people who know about NF1, so they go in and they say, can I avoid an X-ray? And they go, well, we haven't got time for an MRI. And they just don't, they just go straight for an X-ray. There's no discussion. In an ideal world, discussion's brilliant, but it just doesn't happen. It's the same with breast scans. That's all X-ray, and we're telling people to scan earlier, yearly, and then they're having mammograms and not MRIs. And I'm trying to convince non-NF specialists that this is what they should be doing, and they keep just going, well, where's the research? And I'm not a doctor, I don't know anything, but I'm struggling to find research about radiation and NF1 so that I can show them.
There are a number of reports showing that therapy with radiation, so radiation therapy for a tumor where you give a high dose of ionizing radiation, for instance, to the brain or another part of the body, that this probably has more side effects in children with NF1, especially when it's delivered to the brain, than in other children that do not have NF1. So we know that for sure from studies. We do not have hard data to show that CT scans are harmful, but we are cautious. So we know it's also some kind of radiation. It's much lower than the radiation that is used for therapy, but that's why we always recommend, if you can do an MRI scan instead of a CT scan, it's preferable. But it doesn't mean that the regular X-ray has a very high risk, but we are just very cautious because we don't know.
It's avoid whenever possible.
Yes.
Basically.
Yeah, and that's in the guidelines.
Which is what I tell
Yes.
everyone. Sometimes it's impossible to avoid it, but yeah. Okay, thank you.
I have one comment for the person who asked about the diet. Tomorrow at 10:30, there is in the general meeting here next door a session by Miriam Bornhorst, and she is going to talk about metabolism, so everything that happens in your body, all metabolites, and she also will refer to some forms of things that we eat and metabolize, and vitamin D and other things. So Miriam Bornhorst.
All right, we have time for one more question.
Hi, I'm Sophie and I'm from Denmark, and it's not really a serious question. I was just wondering if you had any advice or tips how to take, let me rearrange. If you should give an advice to someone with NF as I have, what would your advice be, how to take care of yourself? just give us a great advice, because sometimes we just need advices.
I think you're clearly doing a great job. You're here. I think in the setting of a rare disease, we've talked about the difficulty accessing adult expert care and how that's impacted many people in the room. I think my advice is, to the best of your ability, educate yourself and empower yourself using trusted resources. So I think the fact that you're here suggests that you're doing that, and I think the real challenge is go back to your city or your country and identify who's not here and who can you share trusted resources with and help empower them to make sure they're getting the best care possible.
And try to educate also medical doctors. You have to empower them to look for the latest news and to know how to handle rare disease.
When I'm probably the oldest one of the three here. When I started in the neurofibromatosis community, it was said that you need to take care of children, and then adults, you could send them back home, and if there was a problem, they should come back. But what we noticed is that if there is a problem and they come back, it might be too late in certain situations. So what we have learned over the years is that it is also relevant to do a regular surveillance in adults with NF1. Also, if they don't have any complaints. We think that every 2 to 3 years, having a consultation in an NF expert center is recommendable. So we recommend that. And as has been said before, it is not so easy to motivate people to do this, because if you're feeling fine, why should you go, right? So we have learned now that it is important, and we are developing newer and newer methodology, like very specific blood tests, very specific MRI scans with all the technology that we have to make better predictions of what's going to happen if we see something in a patient that is not causing any symptoms, because we don't want to harm this patient by taking this tumor out, but you also don't want to harm the patient by leaving it in and having it causing trouble later on. So we have a lot more knowledge now, and one of the important things is to motivate peers, so people that you know, adults with NF1, that it is relevant to have a regular checkup.
I think that's all we have time for. Thank you all very much.
All right, so thank you again to our panelists for answering questions. I hope that that was helpful for some of you. They will be around, and I'm sure they'd be happy to discuss questions with you if you didn't get a chance to get your question answered. We're going to be taking a break here shortly, but before we do that, like I said, we spent the whole morning telling you that we want your input, we want your feedback, we want you to tell us what's important. I heard in a lot of those questions things that you feel are important, that it's hard to communicate with general practitioners, it's hard to get in front of specialty clinics, especially as an adult. So those are the kinds of things that we'll be brainstorming around this afternoon. But before we do that, I just sort of wanted to walk you through what the brainstorming process is going to be that we're going to use today. We are going to keep it short and snappy, and there's a reason for that. And so I just wanted to sort of set the stage for what this will look like after we get back from the break. So crowdsourcing is a very common thing in all industries. It's the idea that if you always ask the same people the questions, you're never going to get any new ideas. And you're not going to get all the various perspectives, and you're not going to get that breakthrough innovation, because everyone thinks very similarly. And so that doesn't just work for Apple and Microsoft. It also works for medicine and the development of treatments. So we want to engage a broad and varied group. We want to ask a variety of people. We do want to ask clinicians and researchers, but we also want to ask patients. As you can see through our survey results, there's some disparities there and some disconnects. We also want to ask our pharmaceutical partners, what are the challenges, so that we can all work together to come up with a solution that works for everyone. And so, we can do this to fund research. We can do this to identify types of education that are needed. And again, this is not just patient education. Maybe we need to develop resources to educate primary care providers. Maybe we need to develop resources to educate people who are in medical school. Maybe we need to develop resources to educate your teacher or your neighbor, so it doesn't just have to be patient-focused. How do we raise awareness? How do we make more people understand? I've heard said that NF is the least rare disease. Like, it's the rare disease that you should have heard of because it's 1 in 2,000 is not that rare. And yet we do know the names of diseases that are far rarer. So how do we just build awareness so that we can raise more funds? So any of those things could be a topic for brainstorming. And so the other thing is it builds community. If everyone has a voice in what the problems are and the potential solutions, then everyone is invested in making that happen. And so we don't have to get a patient buy-in for an idea developed by pharma, right? Because it was co-developed, everyone's already on the same page. And so it makes it a lot easier. So we get faster problem solving, we get diversity of thought, and we wind up with unexpected solutions. This is where those breakthrough things come from. So what we're gonna do, we're gonna get back into the groups that you guys were in after break, and you're gonna decide who your facilitator is going to be. I have a few people I've pre-identified that we can have act as facilitators, and they will be helpful in that role, but if your group doesn't have one of those people, we need to make sure that we have someone who is going to facilitate, which basically just means keep everyone on topic, keep the conversation moving, make sure that we're achieving the goal that we're trying to achieve. We're going to establish the context, which is we know we're trying to identify what are the roadblocks and potential solutions in a given area. We're going to define the objective. So like I said, from our surveys, we pre-selected some, but we're going to give you the opportunity to let me know if there's something else that you feel like is more important than what was identified in the survey, because we want this to be really relevant for you and your group. Set a time limit. Everyone does better when they're compressed for time, because then you have a sense of urgency. We're going to capture every single idea that gets thrown out there, no matter how wild and crazy it is. Okay, that's part of what happens with brainstorming. And the reason we do that is, one, we don't want anyone censoring themselves. Two, you have no idea what that might spark in someone else's head. And three, sometimes we can combine the crazy ideas with something else that makes it suddenly feasible. So we want to capture all of the ideas. And then what we're going to do is we're going to give you some time to discuss and vote. So prioritize. Can we combine any of these ideas that we have? Are there some that we feel like are more important than others? And then at the end, we're going to turn that into action by having each group share one of their top 1, 2, 3 things that came out of their group. I'm going to take that information and I'm going to use it to inform the CTF strategy going forward, whether that be developing a brochure, putting out a specific grant that will address a specific kind of research, whatever that might be. And then I'll be able to report that back out to you within the next year that we've actually taken action on the ideas that you are putting forward. So again, we want you to be involved. We want everyone who's a part of the NF community to be involved in identifying and creating solutions for the problems that exist today. So, guidelines for great brainstorming. Quantity rules. Again, no idea is a bad idea on the brainstorming part of this. Throw everything out there, as many things as you can. That is going to help us get to the right idea. Focus on the positive in someone's suggestion. So again, it may seem completely outlandish. It may seem totally bizarre. It may seem completely out of left field. Just focus on what the positive aspects are of that suggestion for right now, and that might help us figure out, maybe we can't use all of that idea, but maybe there's a part that we can pull out. Welcome the unusual. Again, thinking outside the box. We want those things that are not the solutions that have been tried over and over and over again. And then combine and improve. So when different individuals have different ideas, is there an opportunity to combine those two ideas together and then come up with something that's even better? So we have a poll that we are going to do. You can scan this QR code, or you can go to Poll Everywhere. I need to advance to the next slide?
Yes, once everyone scans.
Okay. I still see a lot of phones up, so I'm going to wait a second, and I think I'm standing in front of the code. Okay, I'm going to move this way.
It is receiving responses, but we'll leave the QR code up just until we see more.
Okay. So what you should see once you get in there is a list of the topics that we discussed earlier, and I just want to see what people are most interested in. And then we'll make sure one of our groups at least tackles that topic. And then during the break, if you have suggestions or ideas for other topics, you can come up and see me, and maybe we'll add in something that wasn't on our original list. Okay. All right, here we go. Oh, we're still moving all over the place. All right, so barriers to participation in research. No. Oh, okay, I'm not going to say anything until this is done. I know, it's just all over the place. Which, I mean, I think goes to show, right? There's a lot of opportunity here. And so the more things like this we can facilitate, potentially, the more we can find solutions and the more we can drive advancements. And that, you know, we have all of our attendees who are going to be at conference, as Dr. Lee just mentioned, who are working hard in their labs and in their clinics to drive things forward. But there's a role for us as other members of the NF community to play as well, and so it's important for us to figure out how we can be a part of the solution. All right, it looks like we're fairly steady now, and it looks like pain and communicating about NF to the non-NF community are the top two. So I will make sure that at least 2 of our 4 groups cover those 2 topics. I may pull on these other ideas that were close. We've got international research was pretty close, and equity to care, unless someone comes up to me with an idea that they're really passionate about, in which case we may assign that to a group as well. This is what it's going to look like after we get back from the break. The first thing we're going to do is we're going to hear another patient story. So we heard from Amit earlier today. We have another patient, Monique, who is here, and she will share her patient story immediately after the break. And then after that, we'll be back in our groups. And your group will get 10 minutes for free brainstorming. Any idea goes. I have Post-it notes and paper. You can work independently and just write down anything that comes into your head related to your topic. You can work together if you'd rather. Then we will take the next 20 minutes to take all of the ideas, just the hodgepodge of whatever you can think of, and really start to think about, well, how would this work? Can we combine this with something else? What would this really cost if this was a solution that we were proposing? What would benefit the most people? You know, and just try to drill down at that point into some ideas that are actually tangible, feasible, likely, and really have broad benefits. And then we'll spend the last 20 minutes where each group's facilitator will get up and give us like a quick little 2-minute to 5-minute rundown, depending on how comfortable they are, about what ideas rose to the top for your group and what are the things that you felt like were priorities. And I'll capture that information, and then we'll adjourn for the day, and hopefully within the next few months, we'll be able to share back with you that we were able to really act on what you shared with us today. Okay? So with that, I'm going to send you all to break. We come back at 3. Yes. Okay. So you have a break until 3 o'clock.
Welcome back after the break. It's now my pleasure to introduce Monique Aerts to you. She is Belgian, and I think that persons with NF can learn a lot from each other because everybody has its own story, and we can learn a lot from that. Monique has her own life with NF, and
I'm sure we all can learn from her.
Hello, good afternoon. My name is indeed Monique, and I am 62. I will try to tell you a little bit about my life with NF. When I was born in 1961, I only had one big birthmark on my tummy and a little one on the side. Besides that, nothing else. I grew up as a normal child, played a lot. I liked playing a lot more than studying, of course, but I was able to go to a normal school. Around the age of 14, I started to see strange things on my tummy. I saw a few little bumps, and we went to see the family doctor. The family doctor at that time told me, "You have the disease of von Recklinghausen." He took this big book, opened it, and showed me the pictures. I started to cry, not knowing what this was. So he said, "Nothing to worry about. You are just a factory of little bumps." And that was it. We went home with all these questions going through my head. At that time, there was not so much knowledge or information available about this disease. Internet and Google did not exist at that time. We didn't do anything further because I was not feeling ill, and I was still able to do all the things I liked, go to school and having fun. My brother does not have it, and neither my parents, so as far as I know, I'm the only one in the family. After finishing high school at 18, I started working, and I must say that I worked for that same company, for 43 years, full-time job all to the end. In 1990, a lot happened in the world of neurofibromatosis, of which you all know a lot more. At that same time, an association was created in Belgium. I got in contact with other people who had the same disease as me. The years went by, and I was still able to do everything. Working, lots of traveling, see the world, sports, enjoying all the good things in life. I did not have too many bumps, and therefore not visible for other people. And I had a lot of friends and a very good social life, and I still do. I must say that neurofibromas grew more and more only after I was 40. Now I have bumps everywhere, all over my body. What I really do not like are the bumps on my face, neck, and my arms. I hate it when people are staring and when it's difficult to hide. I started to read more and more about it, and I was trying to accept it. I did not want to accept it. I started to look for solutions. This was the first time I went to see a plastic surgeon. She removed a few bumps, and this went on for a few years. Through the years, I learned that it takes a long time before a medicine can be found. This is a big challenge for all of you. I'm still hoping someone will come out and that I will still be able to use it. On a regular basis, I go to the university hospitals in Leuven and Antwerp in Belgium for checkups and have full body scans, MRI, and other examinations. And now to end my little story, I could go on for a few more hours. I want to inform you about the symptoms that I mostly have. Cutaneous neurofibromas, lots of them. Back in 2015, a GIST tumor was discovered thanks to a full body scan, which I think are very important to do that on a regular basis. And it was done under supervision and on request by Professor Legius and was successfully removed without any complications. When doing the MRI for my brain and my back, they noticed I also have some type of liquor hypotension syndrome, and I was informed that this might also be related or linked to neurofibromatosis. I also had a glomus tumor under the nail of my little finger, which gave me a lot of pain. And after removing that tumor, the pain was gone. I am not taking any medicine, never did. Only the last few years, I'm taking Zaditen retard. I'm taking this because I was informed that Zaditen contains ketotifen that might help slow down the growth of fibromas. And of course, it also helps against itching. So I must say that I'm a person with neurofibromatosis that did not have too many medical problems, and I had a, as you could say, rather normal life. I want to thank you very much for listening to my story and for everything that you do for people with neurofibromatosis. Another person I want to mention is Professor Legius. For me and for everyone else in Belgium and the rest of the world, he has done so much, and we all would not be here without him. I've seen him many times in different occasions and consultations, and know him very well. He's the best. Thank you very much.
You're good.
If someone has any questions, you can ask. I can see if I can answer them. No.
Thank you. All right, so we've made it to our final hour of Patient Day. And I hope that you enjoy getting to hear from some of your fellow patients who do have NF. And thank you so much for sharing your stories. I know that that is incredibly difficult to do in front of a large group of people sometimes. But as Amit mentioned earlier, it does empower us all to hear another person's story to then feel comfortable and confident in our own. So if we'll go back to our brainstorming groups, you will notice there are some post-it notes and pens in the center of each group. Feel free to use those if you want to just jot down any of your ideas. I'm going to come around to each group and give you one of those 4 topics that was at the top of the list. And you'll have 10 minutes to just go crazy. Any ideas on the table? And then I'll let you know when we're going to transition to actually trying to refine those ideas into something that we can then present on. Okay? Remember that you need to have a facilitator. So make sure that you decide in your group who's going to be the one who will present your information. For our group over here, we're working on having someone to help. So we'll make sure we can get your information. Okay, great, thank you. So go ahead and go back to your groups. The clock is going to start with our 10 minutes of brainstorming. All right, guys, we are at time for brainstorming. So we are moving on to the narrowing and combining. That doesn't mean new ideas can't be put forward. They still can. But the focus of this next 20 minutes is to combine ideas, prioritize ideas, decide which things may have the most merit, might benefit the most people, however you want to figure out of all the things you have, what are like the 1 or 2, 3's pushing it, no more than 3 ideas that have come out of your group that are either the biggest barriers we need to overcome or potential solutions or audiences we need to address, things we need to fund. What comes out of each group might be slightly different, and that's okay. But sort of what are the 1 to 3 main takeaways for your group, okay, in the next 20 minutes? And make sure you know who's going to be sharing for your group. You'll have 2 to 5 minutes to share with everyone. All right, we are at the end of our brainstorming and narrowing time. So we're going to start, we're going to give each group 2 to 5 minutes to share some of the top ideas that they came out of their group. I'm going to capture those, and then I will follow up on the actions. After that, we'll have a quick closeout by both our sponsors and our Patient Day co-chairs. So is there a group who's wanting to go first? Who's ready? No groups ready. All right, we're going over here.
Yes, our topic was international clinical trials, and our idea is, for example, to make something like a WhatsApp group that you can get an information that there is a clinical trial, or an application combined with a platform like NF registry, but more patient related, that you get simple, easy bullet points, for example, with age and type of schwannomatosis or NF, so that you are informed in a very short way which clinical trials are running. And the last thing was that we would love to have a registry for physicians, that they can register patients, and then they get a feedback if there is a clinical trial, and they can get back to their patient and say, okay, I got informed that there is a new clinical trial outside. Do you want to participate? That's it.
Thank you so much. Trying to take notes and facilitate at the same time. All right, do we have another group who's ready? All right, group in the back. Tell us what your topic was, and then give us your top ideas. Also, I do want to point out what happened over here with their Post-it notes. This group was clearly invested.
Well, we were very invested because our topic was pain, so something that's near and dear, unfortunately, to many of us. So we had three broad categories of ideas. One was recognizing that psychogenic or emotional pain and physical pain are all part of the same process. And so recognizing the need for both mental health and psychological support along with the medical physical support for pain. The second broad category was looking at the importance of being believed when we talk about pain, and avoiding gaslighting that unfortunately many people encounter, and recognizing the need for objective ways to measure pain. And the third area had to do with treatment and the importance of being able, whether it's on an individual or I guess we could say collective basis, to look at all options to treat pain. So both traditional Western pain treatments as well as complementary health approaches that many people are using very effectively. In fact, I can tell you sometimes it works better than traditional Western medicine.
Wonderful, thank you so much. Did I see a hand?
So our topic was how to educate non-NF to the NF community, like how to educate, yeah. And one of our topics was that we should get people as young as children, like get them to know what NF is and that it's not contagious, and that my classmate is perfectly normal, that I can play with him anyway. And some of the things that we really wanted was like some material that we could give out to children and their classmates and the teachers, and educate teachers about NF, and also that so parents feel more safe sending their kids to school and like having a playmate, like that's really important for parents, that they are seen, and then that children also are seen by other children as not normal, but yeah. And also we talked about hosting events, like in Holland they have a Run Expected, where you go on a run and you might encounter something unexpected. And we really want to imply that in also other countries, so that we can have some fun events and really raise awareness, so that other people that would maybe go on a normal run or run a marathon also could participate in those things, so that we could raise money and awareness at the same time, which is great. I think that was all from here.
Great, thank you.
Hello. Before I start on my topic, a big shout out to the team doing the translations, because I've just been doing this in French, and now, yeah, my French isn't that good. So anyway, our topic was access. One of the topics we talked about was physician training and physician knowledge. And there, I mean, solutions, we talked about a lot of different things, but one of the topics is potentially using information technology to disseminate information to physicians through e-learnings and things like that. Another topic that was associated with that was consistency between treatment decisions by... Oh, so much? Okay, sorry. Is differences in treatment decisions by physicians of the same specialty. And there again, potentially information technology can help through establishing precedents in terms of what decisions are made based upon particular treatment pathways. Obviously, we don't really have insight into what's already in place there, but that was an idea. We also talked about the access to medicines and potentially different availability of approved drugs in different geographies, which can be challenging, and of course the price of reimbursement. We covered a lot of topics, so we talked also about access to psychological care, which for most of our group, they said it's not actually a problem to access it, but there's still a lot of social stigma associated with that. So training and awareness is quite important there. And the last thing, and I think it's a theme that's covered generally, is around general awareness in society about the condition of neurofibromatosis, and there around making a big noise in communication, getting celebrity spokespeople, having sporting events, sponsored events, things like this. And of course, financing is always an issue, and we talked about the potential of endowments and legacies and things like this to help improve the financial funding of treatments and care, as well as to advocate to politicians, right, to MPs and things like this, to ask for a bigger share of the health and social care pie when compared to things that maybe get a bigger public profile. So that's what we discussed. Thank you very much.
Thank you. Wonderful. Well, I think that all of our groups came up with some really amazing things, and I'm very glad that you all were able to share those insights with us. I hope you found that a good use of your time and found that beneficial. We will be sending out a survey after Patient Day to get feedback from you all on what you liked and what you didn't like, so that when we do future patient days that we can take that information and hopefully make them better and more relevant over time. But we're about to close out now, so first I'm going to hand it over to Alexion, who was our sponsor for Patient Day. So very grateful to them for helping us fund this opportunity.
My name is Matt, and I'm here as a representative of Alexion, just one member of a really wonderful patient advocacy team we have across the globe. And I think one of the best parts of our job is we have the honor to serve and elevate the work of organizations like the Children's Tumor Foundation. So I want to acknowledge CTF and Sarah. The work that went into today started many months ago, so thank you to Sarah. And I've been lucky to be a part of a number of these over nearly 2 decades, and I can't think of a time where there was a more global representation and some of the leading experts in the world, not just NF physicians, but these guys are too humble to admit it, but they are really at the cutting edge of what NF-ology looks like. And so to get a full day of their very busy schedules means a lot, so thank you for your contribution. And then lastly, thank you to all of you guys. We talked in our group about self-advocacy and needing to show up sometimes, whether it's at a doctor's office or with friends and families. And I can't think of a better example of self-advocacy than finding yourself in Brussels at an event like this on a Friday to spend all day. You guys all have very busy lives and you have other things going on. So as a member of the NF community, as somebody that works in NF, thank you. Because events like this, your opinion, your time, your care, this is how we're all going to work together to end NF. Thank you.
And then lastly, I want to turn it over one last time to our co-chairs to close us out. Thank you so much for your participation.
It has been a long day, but I'm convinced it was a very productive day. So we're now at the end of the sessions, and I also want to say thank you to Sarah for organizing everything. Thank you to my co-chairs for being here and for Alexion for sponsoring. And thank all of you for being here and being so productive, for asking questions and being very, very interactive. Thank you very much.
That's it. So if you did buy a ticket for the dinner tonight and you want to sort of hang around, everyone is welcome to the awards ceremony, which will be taking place in the auditorium at 4:45. We'll be recognizing some researchers who have really made significant advancements over the last year. You do not have to attend, obviously, but if you would like to, you are welcome to join us there in 4:45. Otherwise, I wish you a wonderful day, and thank you so much.
Thank you so much for joining us on Patients Day. If you used our translation services, please remember to drop off your headset in the back of the room. Thank you.